Primarily works, wonderful. She primarily works in philosophy of mind, philosophy of language, clinical ethics, and how these areas relate to pain. Her focus is on pain communications, particularly the context of racial and gender disparities in pain management. She is currently doing research as a neuroethics fellow at the Cleveland Clinic. Prior to that, she was the inaugural Sadler Scholar at the Hastings Center and a visiting scholar at the John L. Lynch Center for Ethics Program for Neuroethics and Clinical Consciousness. Her education is a background of a BA with a philosophy degree with honors at Davidson College, followed by a PhD at the University of California, San Diego in 2023 with a dissertation, "Let Me Have Your Attention!" exclamation mark, taking pain utterances seriously. So today, her topic is, pointedly, taking pain dismissal seriously, exploring interpersonal and structural barriers to pain communication, in which Dr. Wiggleton-Little will describe the various ways in which patients who are already members of socially marginalized groups will experience pain dismissal and will propose practical recommendations for addressing communication barriers. And without further ado, I shall stop sharing. And Dr. Wiggleton-Little, the screen is yours.
Perfect. Hopefully I can do the general Zoom question if everyone can hear me. Screen can be seen. Perfect. I see in the chat that people were asking about the CME credit. I've also included the barcode here on my first slide. So again, thank you so much for having me to share more about my work. As mentioned, my dissertation looked a lot at what is it that we do when we communicate pain? What is it that we're trying to convey or even communicate? And then as time has moved on, I became even more interested in, okay, once we figure out what it is that we're doing when we're communicating pain, what are all the ways in which that pain communication can go wrong? And so that's going to be our focal point for today's conversation. So again, my presentation is going to be entitled Taking Pain Dismissal Seriously, and we're going to be looking at both the interpersonal communication barriers as well as the more what I call structural barriers. And so whenever I give a talk or give a presentation, I always like to ground my work in real life experiences, stories that's told by patients. You know, philosophers, we can be very famous for starting with a thought example. And what's beautiful, but also kind of unfortunate about pain is that so many of us have these kind of real lived experiences of what it is to feel like our pain wasn't truly heard. And so I always want to start with sharing a real experience. So this example that I'm talking about today was an opinion piece posted in the LA Times by Tiffany Unique. And she is an African-American woman who, when she was pregnant with her second child, started to feel this excruciating pain in her pelvis. And when she tried to communicate that to her obstetrician, the white obstetrician said, well, it's normal, right? Or how I interpret that is, of course you're in pain. You're in labor, right? It's expected. So even though she tried to communicate that she had never felt such pain before, she was told to just take small steps like a geisha. And then when she began to start giving birth, she knew something was wrong. It felt as if her pubic bone was broken. And again, she was reassured that this is a normal experience, right? This is what is expected of the female body during this process. And suddenly, Tiffany starts to remember that prior to being in labor, she was warned that she may have had a possible pubic rupture. And then the doctor asked her to show her what that meant, but she couldn't demonstrate that at the time because she was active in labor. So she was directed to lay on her back, the way in which the obstetrician was trained. And then when her baby arrived, Tiffany found herself paralyzed from the waist down for some minutes. She says, then the pain crushed into my hips and I began to scream. As a Black woman, she's accustomed to, and I quote, my pain not being taken seriously by doctors. And so later on in the same article, she writes that in fact she did have a fracture in her pubic bone during labor, that she was certain that fracture existed prior to labor, and that as she continues to work with this obstetrician, she never received an apology. She was told to continue to do physical therapy. But again, it kind of relayed this multiple messages of my pain not being taken seriously and something about what she was expressing or communicating being interpreted as normal, right, as expected. And so for this reason, I argue or like to highlight that there's many different ways we can interpret what happened in Tiffany's case. Often when we talk about pain dismissal, especially I like to look at how news articles are talking about pain, philosophy literature, bioethics literature, medical humanities literature. We always talk about pain dismissal in this one form, right? Someone's not seen as credible, like that we don't believe the patient. And particularly if because of some kind of gender or racial identity or some combination of the two. And so our first explanation could be, stereotypically speaking, women are more likely to be perceived as hysterical, as emotional. We're more likely to be told that pain is all in our heads. If you belong to a racial ethnic minority group, when you're complaining about pain or trying to just communicate your pain, you're more likely to be perceived as drug seeking, as having some kind of secondary gains as to why you're communicating your pain this way. And then, being an intersectional identity as a Black woman, we have this combination of the gender stereotypes paired with the racial stereotypes. And we have this unique way in which Black women are perceived as incompetent, especially when it comes to communicating about their own lived experiences. In fact, author Teresa McMillan Cottom wrote in her essay, her collection of essays 6, that she experienced a similar situation when she was experiencing labor pains. I believe she was about 3 to 4 months pregnant. She started to feel this strange pain in her lower back, and she tells her doctor, something doesn't feel right here. Tracy was also overweight, so she was an overweight Black woman. She was told, oh, you just need to lose weight. It's probably something that you ate. She went back home that same day, was still experiencing pain. She calls in to her doctor's office. The nurse says, again, what did you eat? It's probably just indigestion. She proceeded to experience labor pains for about 3 days before she finally goes into the ER and had to convince individuals in the ER to run some imaging. And that's when it was discovered that she had been going into active labor for the 3 days. She ultimately lost her daughter, and she writes in her essay, as she is holding her daughter in her arms, the nurse said, if only you would have told us that the pain was in your butt and not your back, we would have known you were in labor. And she reflects on this and she says that in that moment, she was reminded of the feeling of being incompetent as a Black woman, that she wasn't seen as knowledgeable of what it was that she was communicating. And she compares her experiences to the well-documented story of Serena Williams in her experience of labor as well. But it's not just whether Black women are seen as, again, credible. How can we believe what pain they're sharing? But what is the perception of the Black body, the Black biological form? And there seems to also be this thought that as Black women, you're more likely to be perceived as superhuman, that you're sturdy, you're gritty, like you can take this. Your body was meant for this pain. And whether or not that is doing some contributions to the experiences of Tiffany that Tiffany shared in her opinion piece. And then lastly, what I hope to also show is not only do we have these racial gender ideas of who's more likely to be believed, who's more likely to handle pain, but even when we talk about certain pain experiences themselves, we seem to normalize certain pain experiences. And labor pain seems to be a primary case. It's just normal for the labor process to be excruciating. And when we have these kind of narratives, sometimes it's harder to imagine a secondary cause of pain. We're less likely, less motivated to search for another explanation as healthcare professionals. And this has been well documented as well. So it's hard, the long story short is, it's hard to say that there's a single explanation behind pain dismissal. And I worry that when we only talk about pain dismissal in terms of race and gender credibility, we're really missing some complicated contributions on multiple forms. So not only do I think there's multiple barriers that we're going to talk about today, also in my work, I talk a lot about what does it even mean to take pain seriously? We hear this language all the time from patients. They didn't take my pain seriously. I want you to take my pain seriously. What are we really conveying, or what is being expected from us when someone makes that kind of claim? And what I've argued in my dissertation and in other papers is that I think when we communicate pain, that we have two purposes. One, of course, is to share knowledge, share our belief that we are having pain, right? And to share that knowledge in a way for then healthcare professionals to act on it or to factor it into their diagnostic assessments. But it's not just the point of sharing pain is to share knowledge. Historically and evolutionarily speaking, even if we're not using language, verbal language, whenever we grimace, cry, even as infants, a huge point of our communicative aim seems to be to elicit care and concern from others. It's to be motivating. So in some real way, if I told you that I had a headache, a chest ache, a stomach ache, and you believed me, but seemed to not care, not be moved to concern, not act on it, that still seems to be a way of not taking my pain seriously. And so for that reason, I break this down into two interpretations. When a patient is making this claim, you're not taking my pain seriously, I think we can interpret that as one, not taking pain epistemically serious. And by that, I mean, when we have these moments where either a patient or their pain report is not believed, or neither are perceived as sharing credible information. How do we often know that a pain is not being taken epistemically serious? When you hear language like, oh, are you sure it's not in your head? Are you sure it's not stress? Are you sure it's not something else? I don't know if you're really in pain, right? That language of doubt that's being communicated. How do we know that we're not taking pain motivationally serious? The way I define that is when a patient or their pain report is not being perceived as worthy of a heightened attention or concern. And again, I think there are cases in which we believe a patient's pain, but we're just not moved by it, right? And a good indicator that this kind of form of not taking pain seriously is occurring is when you say statements like, oh, it's just a period pain, right? It's just a labor pain. Or, lessons that we sometimes tell our children, for better or worse, get up, brush it off, right? It's not that we're doubting what they're experiencing, but we're saying that there's no reason for alarm. Like, I'm not moved to take this as a heightened behavior priority for me, either as a caregiver, outside of the clinic or in the clinic. So I want to make sure that when we're talking about these barriers to pain communication, that some of the barriers I'm going to describe are going to influence not believing the patient, and some of these barriers are going to influence how seriously, from a motivational standpoint, how moved or concerned we are by these pain from that perspective as well. And so to begin, let's first discuss interpersonal barriers to pain communication. And so when I talk about interpersonal barriers, I'm talking about the person-to-person interactions, right? What is happening within the examination room in that one single conversation? As many of us know, pain is, by definition, seems to be pretty essential to what pain is, subjective. I know I'm in pain based on how I experience it. And so for this reason, we have this understanding that it's hard to say whether there's a capital T truth to what pain is, but at least pain as understood and felt and experienced by the patient is our ground truth, right? It's the truth in which we operate on and that we take to be as true as it gets. We have no other more reliable assessment of pain other than the patient's pain report. So when I'm talking with you, I can only know how much pain you're in based on how you communicate that pain. But when we're talking about these forms of patient's report or pain communication, a lot of that requires trust. Trust that the person is being sincere, trust that the person understands and has some form of conception of what it is that they're trying to communicate to me. And so a lot of the barriers we're going to talk about are going to be ones that's going to either make it harder to find that person credible of what they're sharing, or make it harder for us to trust that they're being sincere in what they're sharing. And so our first barrier, of course, is what is it to even express pain? And when we're talking about pain expressions, we're often having some gendered notion or gender stereotype of what pain behavior should look like and who gets the right to share and complain about pain. And I use complain loosely of women are more likely to be seen as complainers, as those who are overly expressive, hysterical, right? We just can't handle the stress. So it's more expected for us to share our pain. But then that comes with kind of bites us in the foot in a way, where because women are uh, allowed from a gender standpoint of expectations to express pain and even expected to express pain, they then get cast as overly expressive. So in studies, one was done at University of Miami, showed that even when women and men complain about the same intensity of a shoulder pain, so by intensity, I say on a scale from 1 to 10, both women and men in pain rated their pain a 6. So even when the intensity shared was the same, their facial expressions were the same, women on average were given a lower intensity by the healthcare professionals. Even though they were rating a 6 or a 7, healthcare professionals were underestimating how much pain they were in. And the researchers argued that part of that underestimation that's happening is because of these stereotypical ideas of how do women express pain and being overly expressive, while the opposite also occurs in men. Because we have this stereotype that men are stoic, and not even descriptively, but that they ought to be stoic, right? That you're supposed to grin and bear it. That when a man finally does express pain to a level of 6 or 7, we can argue that while women are given a credibility deficit, their credibility is unfairly downgraded. Men on average are given a credibility access, right? Because you actually shared your pain, whoa, it must really be bad, right? I have to act on this. So men were more likely to be perceived to benefit from pain medications. Again, with this kind of stereotypical pain expression behavior in the forefront, while women who express the same level of pain were more likely to have their pain underestimated, and then when given a treatment plan, were more likely to be perceived as benefiting from psychotherapy. Again, this kind of enacted stigma, enacted idea that women are just overly expressive, which causes us to downplay or downgrade how much pain we believe they believe that they're in. And so we see a similar kind of prejudice bias influence when it comes to race and credibility assessment. So it's gendered in the sense of who can express pain and who is expected to express pain and to what intensity. And then when we talk about racial bias, we're talking about who's more likely to be trusted and believed. And so bioethicists Daniel Buckman, Anita Ho, and Daniel Goldberg had a paper that came out looking at epistemic injustice, trust, and chronic pain. And they noted that the credibility of a patient's pain report is more likely to be questioned if they belong to a socially marginalized group. And apologies. And with this same idea is not only in past slide I mentioned, racial and ethnic minorities are more likely to be perceived as drug seeking. Studies have shown that healthcare professionals are more likely to lean into their prejudice and bias when we don't have that already established relationship with the patient. And when we are in high stress situations, right? When we have to make these quick decisions, it's easier to fall back on the biases that we have, which is why some of the studies that we are looking at, particularly where the credibility is more likely to be downgraded in racial and ethnic minorities, is in the context of the emergency room. And so even thinking of the social determinants of health that come into play, where those who are from racial or ethnic minorities may be less likely to have access to a primary care provider, more likely to get their care from the emergency room, but not having those established relationships with care providers who are more likely to lean onto their prejudice, right? It becomes this kind of storming effect. And one thing that we've seen is that Native Americans were more likely to be perceived as exaggerating their pain within this context, and that Hispanics were more likely to report this feeling that I wasn't believed by my healthcare professional. And another well-documented example, of course, is patients with sickle cell who may enter the emergency room during sickle cell crisis, also feeling this, I was automatically assumed that I was coming for drugs. So it's this combination of where your first step is to get healthcare, especially in times of crisis, not having these established relationships, high stress situations where we're leaning on our bias, and who's more likely in those contexts to then be perceived as either drug seeking or just simply exaggerating. And so those first two barriers we looked at focus more on, what I call that epistemic arm, not taking pain epistemically seriously. Who's less likely to be believed? The second arm is going to focus on, well, this next barrier that we're going to discuss is focusing on our who's more likely to be motivated arm, right? Who's more likely to be able to elicit care and concern by communicating their pain. And I argue that this kind of superhuman bias in pain perception plays a big part in that. And so in other works, people will often talk about how especially Black bodies are dehumanized historically. How are they seen as non-human? And we're described in these very animalistic terms. I argue, and I think a new language that's starting to emerge as well, is that it's not just a dehumanizing bias, but in fact, it's a superhumanizing bias. It's that there's something about these resiliencies of what they call physical peculiarities of Black bodies that makes us be able to be insensitive to pain, that we're able to withhold it in ways that those who are seen as more human and have the rights of humanity do not. And so we start to see this narrative of the superhumanness of the Black body in the 19th century by prominent physicians who are trying to establish this distinction between Black bodies and white bodies. And so some of these peculiarities that they described were the thick skulls. They claim to have observed less sensitive nervous systems and that there's certain diseases that's inherited to the Black skin. And so one physician even wrote down in a medical journal, and I quote, "Negro disease makes them insensible to pain when subjected to punishment." And this narrative continued on, especially during the time of enslavement in the United States, where we're seeing experiments done on Black individuals, especially Black women. And it's also a belief system that is still present today, even though the language has slightly changed. So a very famous paper came out of University of Virginia by Huffman in 2016 that showed from first-year med students to residents to staff physicians that at least have had these false beliefs of biological differences between Black people and white people, and that these biological differences, those who had those beliefs were also less likely to prescribe a certain strength of pain treatment to Black patients. So there's some correlations of, again, who do we think is worthy of some more intense treatment in an alarming way, and whose bodies do we interpret as being able to withstand and kind of endure these pain experiences. And it's arguably these beliefs don't only exist in the health space, that even these narratives we hear that, Black individuals are naturally good at sports, right? That their bodies are naturally athletic, naturally strong, is really a language that's found in our whole society's discourse. And so it's not just the belief on how we perceive the body itself, but even what expectations do we have of people that reinforces that idea. And so an example that I think was very relevant to our starting story is the idea of the strong Black woman schema. You have to be a strong Black woman. And that schema is this idea that the ideal Black woman should have emotional restraint, independent caregiving, right? That you should be able to wear it all on your shoulders and not break. And it's the same schema that many Black women who are patients report that when they come into healthcare facilities, they feel like they have to dress a certain way. I can't look weak. I can't look sick. I have to look presentable. I can't really share what it is that I'm going through. And so it's this masking of suffering that occurs, and this kind of presentation that I'm unshakable, that I'm unmovable, that can reinforce this narrative that already exists in biomedicine of, well, they can withstand certain pain stimuli without saying something. So obviously their bodies are more, capable of handling it, right? So it's not, in a way, I argue, it's not the same of what we see of racial and ethnic bias of who's credible, right? Who's trustworthy. Instead, it's a not taken seriously of, no, I recognize that you're in some kind of pain, but that you're not expressing pain to a degree in which I have to be alarmed by it, because maybe there's something about your body makeup in which, again, you're able to withstand this in a certain kind of way. And so those are this kind of dominant narrative that we would need to also address. So again, the first half, we were just looking at these barriers on the interpersonal level. What's going to influence the individual healthcare providers' conversation, perception of what's being not only just communicated verbally, but also how that body is grimacing or showing the body and the intent of the individual, showing and communicating pain. And then the second half, I want us to look at, well, what barriers exist on the structural level? And by structural level, I'm going to be citing some work by Carroll and Kidd here, of kind of like hermeneutical injustice that exists in medicine. And so by hermeneutical injustice, we're looking at what language, what concepts, what conceptual resources and social health practices do we have? And how do those work as barriers to understanding the patient's pain experience? And so some would still be unique to whose pain are we more likely to take serious, but also some of these barriers on the structural level of how are we trying to measure and define pain seem to be a barrier for any and all patients in pain. Of what is it to communicate that just unique subjectivity of a pain experience. And so one part that exists on the structural level is again looking at what are our language, what are our concepts when we're talking about certain kinds of pains. And so primary example I talk about in other projects is menstrual pains. Okay? I think menstrual pains is a primary example of a case in which we believe those who are menstruating, we believe they're in pain. And we say, well, that's just what it is to have a menstruation. That's just a part of life, right? This is normal. This expectation to cope, that even if it's excruciating, we find that healthcare professionals are less likely, again, to look for this secondary explanation because of this biomedical narrative that even if a menstrual pain is excruciating, that's just what menstruation is. And so this excellent book, Unwell Woman, Misdiagnosis and Myth in Man-Made World by Eleanor Clayhorn, she kind of does some medical historian work here. And again, a lot of interesting findings were happening in the 19th century. But as early as the 19th century, we start to see that medical journals were reporting that pain and emotional instability was just, again, this normal experience of menstruation. And so she went back and looked at some of the first reports of menstruation and saw that who were publishing these reports were male physicians who were reflecting the patriarchal idea at the time that the female form is biologically inferior. And that those who they interviewed and studied for these research were hand selected and who they had very limited clinical interactions with. Again, at this time in the 19th century, to be menstruating, you were kind of shut off from society. You needed to stay at home. You were in your weakest form. So there was very little interaction with menstruating persons at this time. And it came out later that those who they hand selected and painted this narrative that excruciating pain is a normal experience were individuals who were later found out to have secondary dysmenorrhea. So secondary dysmenorrhea means menstrual pains that's linked to a pathological cause. So what was really causing their excruciating pain was conditions like endometriosis, fibroids, right? But they were being painted as a primary dysmenorrhea. So the idea that these are menstrual pains that just happen to occur in state of menstruation that doesn't have this pathological secondary cause. And so what in the future, women physicians were coming in and trying to change this narrative and say that really when you're on your period, at most you should feel some kind of discomfort. But because we have these narratives, those who may have secondary dysmenorrhea, conditions like endometriosis, are finding that it's getting harder and harder to get diagnosis. On average, it takes 5 to 7 years to get a diagnosis of endometriosis. And the most valid way to diagnose endometriosis is with a surgery. So it is, again, this how much are we really taking seriously these complaints of excruciating pains? And with this expectation to cope, so it's not just do we take that step to pay more attention, to do further investigation? But when you have this expectation I believe you and you should just deal with it, it delegitimizes a person's attempts to adopt what we call illness behaviors, right? To feel like I can go out and seek health care. to feel like I can take a day out of school or a day out of work, right? To have this change and be able to take a step away from your normal everyday obligations. And so we see this delayed diagnosis of conditions like endometriosis on both sides, the patient and healthcare professional, where it's hard to see the diagnostic differential between a normal menstrual pain and one caused by a secondary condition. And on the patient side, it's harder for me to even feel willing to call for help. So there's also this excellent essay by Kalia White, who's a Jamaican woman, and she says she remembered there was a point where her menstrual pain woke her out of her sleep. And she was talking to herself and said, I can't call 911. There's no reason for alarm. What am I going to say? My stomach hurts? They're not going to respond to that. So it's even this self internalizing of this is a normal experience. I too don't even have to be as concerned or alarmed about what's happening within me. And we hear, just wanted to give some more quotes and narrative that patients shared of hearing the societal message of, I'm expected to put up with this. And when we look at this quotes, it's not clear to me again that someone's denying their pain. We're not saying that these individuals are hysterical. We're not saying you're drug seeking. The first quote says he brushes it off and says it's a period pain, right? I acknowledge you're in pain and you can get on with it. That's his entire attitude. Have some ibuprofen and get on with it. The second quote says, I was seeing a female doctor and I remember thinking, great, she would have some sympathy. She just told me all women have to put up with this. And the last quote, I went subsequent times and I always just got told, I mean, it was dismissive. This is what girls go through. It's what happened. It's period pain, right? So again, very much falling into our not being worthy of heightened attention or concern are, not taking what these patients are experiencing serious in this motivational way. And our last structural barrier I want to focus on is what is the epistemology or our way of going about knowledge in the medical space? And one thing that we have as our practice is privileging the objective, right? We love the scientific method. We love ways in which we can make something measurable, quantifiable, and impartial as possible. And so what Carl and Kid have noticed is that not only when we're acknowledging that the patient report is the golden standard, we seem to privilege certain ways in which we articulate those pain reports. So our very infamous pain scales, right? The facial pain scale, the numeric pain scale, on a scale of 1 to 10, with 10 being the worst pain that you felt, how much pain would you say that you're in, right? It's very efficient. It's going to give us some kind of actionable piece of information, especially when we're determining how effective a pain treatment is. If you come in with a 9, and after a few hours after medication, you say it's a 6 or 7, I know our medication is working. But it's reducing all the messiness and subjectivity of pain experience down to a number. So what's really being left out in these kind of practices we adopt? And same even with our short questionnaires, that a lot of questionnaires that use language, we have a preset of vocabulary that we're asking patients to check off. Is this burning? Is this throbbing? Is this piercing, right? Where is it that you find it? So we're trying to take this very messy, complicated state that is pain and really shed away the complexity and make it measurable in that space. And not only independent of the patient pain report, we also have this practice of privileging the impartial, objective third-person reports of pain. And by that, I mean kind of brain imaging of pain. We know that when people are in pain, their blood pressure goes up, right? That's a good indicator. So looking at what's happening in the physical body and privileging that over the patient's pain subjective report. And this is, again, a practice that we've seen historically with medical sociologist Elaine Scarry in The Body of Pain, noting that patients in pain are frequently seen as unreliable narrators. Foucault has made similar observation that any time the patient's subjective report comes apart or is different from what we are objectively seeing in the body, often than not, we side with the objective report. And that's why certain conditions that have less diagnostic certainty, less clear symptom presentations are more likely to be stigmatized and undertreated, because it's having to really lean and trust on the patient's voice And it comes in conflict with what we're seeing on the screen. And because medicine and its roots with science, it's if the screen doesn't show it, that often gets the final say. And this is important to think about of how do we privilege the objective? How do we privilege the body in pain over what the patient in pain is saying? Because as of, most recently, this article came out in BBC in April 2023. In the last 5 or 6 years, there's been a lot of discussion of, can we come up with an objective measure of pain? Can pain truly be objectified? And at some point, it seemed unlikely, but now with progression in science and technology, we're seeing closer and closer to discovering pain biomarkers that are pretty reliable. And so there's 2 primary pain biomarkers available to us. We look at genes in the blood that can indicate not only that someone's in pain, but how intense that pain could be. And also there's some work being done in brain imaging, looking at the presence of theta waves. And these theta waves seem to be present for both acute and chronic pain and seem to be responding to pain medication. And so the thought is, if we can really solidify these objective measures, if there's a way in which we can use technologies like brain imaging, that maybe this can be a way in which we counter bias in medicine. Because again, looking at those interpersonal barriers, the patient report requires me believing you. It requires me trusting you. It requires me to be able to see past my own biases of who's credible, whose bodies ought to be in pain and can express pain in a certain kind of way. I get to bypass all that messiness and just go to the source itself. But of course, there's going to be some limits to pain biomarkers. One, we have to ask, can they even be successful in capturing the features of pain that we want them to capture? But sidestepping that, if this technology becomes available, if there's a way in which we can assess pain reliably with pain biomarkers, can this truly address the disparities in acknowledgement and treatment that we hope for? Pain biomarkers is getting a lot of uptake right now, especially with this movement towards personalized medicine. So there does seem to be a lot of pros in how do we make sure that treatment is actually responsive to unique pain experiences. But I argue it's not going to address the disparities in the acknowledgement piece. Because one, just because I can prove that someone's in pain, if we treat these pain biomarkers as some kind of lie detector test, or even to be able to measure someone's pain, it doesn't address the second part. It doesn't address that for some, there might still be a lack of empathy or concern. So even though I know you're in pain, I might not feel compelled to treat. And we have cases like that, right? Arguably cases of menstrual pains where we're not denying the pain, not in every case, but just, on average, we're not denying the pain, but we still might be missing that extra step of feeling compelled to be alarmed by the pain that we're seeing. Another limit would be that by saying that these objective assessments can address bias, it ignore other social and cultural contributions to disparities in pain treatment. So again, these narratives and expectations we have of who can express pain or, what pain is deemed normal or not, that still seems to be an important part of these disparities that we're seeing. And then lastly, if things like brain imaging to use and identify pain biomarkers in the clinic becomes normal practice, we still have this potential issue of unequal access to that technology. So if we ran with the story of, for those individuals from marginalized communities who are more likely to be, doubted or not believed, that for this population, we can turn to, this test to prove that you're really in pain and then respond accordingly. Often, again, those from marginalized backgrounds may not be in the best financial position to afford this technology. Or it seems to be an injustice in and of itself that for you to respond and treat my pain, if you start from a place of disbelief, that I have to pay, say, $200 for an MRI for you to get to believe that I'm in pain, versus belief, trust, concern is arguably free. And so to summarize these barriers, again, not taking pain seriously can be understood epistemically: doubt, disbelief. We see this with these gendered expectations of women being hysterical, We see this with the racial bias and credibility of you're not actually in pain, you're here for drug seeking. And we see it even on the structural level of when paired with privileging the objective imaging, that patients in pain as a population are deemed to be unreliable narrators. And then from the arm on the motivational side, whose pain do we see as worthy as this heightened attention or concern? Again, on the structural level, what pains are painted in our language, in our medical journals, and our medical practice as normal, as expected, making it harder to say, hey, no, I'm concerned here. I'm trying to get your attention. I'm trying to elicit care. And then still in that interpersonal arm, whose body is more likely to seem to be able to withstand and withhold this pain, right? You're superhuman. You got this. I don't have to be concerned by you. And that even comes in our behavior expectations. And so when we're talking about how do we address these barriers, I borrow a framework from Christy Dodson, who does work on epistemic oppression. And epistemic oppression is the idea of a persistent epistemic exclusion that hinders one's contribution to knowledge production. And so a lot of language that's been taken up recently on epistemic injustice, being harmed in your ability to share information, to share knowledge, falls under this bigger umbrella of epistemic oppression, right? Can I use the resources that we have to get you to believe something? And she says that this exclusion happens on multiple levels, right? It happens in how do we use the practices that we have and do so in a way that doesn't change our practice, right? But still is more just. On the second level, it may require a shift in our practice, right? How do we even come to assess pain? And on this third level, she says, oh, this is the most difficult level to change. This is what do we take knowledge to, what do we take our understanding of knowledge to even mean? And how that could be oppressive of what is knowledge? What is it to know someone else's experience? And I argue the same framework could apply for what we deem as motivational oppression, that we might need to propose solutions of what is it to implement our ability to understand pain and assess pain? What are the resources that we actually use to do that? And so the first recommendations I offer is on that first order level, that if we see pain assessment as in this patient report through communication, then maybe it could be helpful to have a communication checklist. What are communication strategies that both patients and healthcare providers or professionals can adopt? So right now, there's a lot of medical blogs out there that's giving advice to patients of how can you get your doctor to take your pain seriously? Make sure you keep a pain diary. Say, you know, what medications is effective? Where does pain hurt? What language do you use? When does your pain hurt the most? At what time of day? But the resources that I've seen for healthcare professionals seem to be more on the how do you active listen? How do you validate patients' experiences? And so coming up with strategies that both patients and healthcare professionals can see together of what are the questions that we need to be asking? What are the things we need to be evaluating? And what are the languages that I should be using? And if we're going to continue to assess credibility when we're looking at patient reports, I think we have to continue to do kind of this implicit bias training or addressing of race and gender-based prejudice and bias in individual healthcare professionals. But I argue that maybe we even need a what I call pain diagnostic implicit bias training, because sometimes we have bias and prejudice against certain conditions themselves, independent of the race and gender of the patient. Conditions like fibromyalgia, endometriosis, long COVID, these mysterious conditions, menstrual pains, labor pains. How has society painted them in such a way that it takes us extra time to take concerns or reports in those spaces seriously? And then recommendations on how do we change our actual way of understanding pain experiences, that we might need to examine and challenge what we deem as a normal or legitimate pain concern, right? The dominant narrative that we assign to menstrual pains, that we assign to labor pain, and also examine our expectations of how pain ought to be communicated in the clinic. Can it truly be measurable? Right? Can it be quantified in this kind of way? What pain expressions ought to look like could differ for individuals, and how do we start taking those into consideration? And so key takeaways from my talk today, and happy to talk more on any of these points during the Q&A, is that I argue that pain dismissal isn't just doubting patients. It isn't just about a lack of credibility. Pain can be denied, doubted, or diminished in motivational value, downplayed, and that the causes of these different kinds of pain dismissal can differ. We have racial prejudice, gender prejudice, normalizing certain pain experiences. And thus, when we're talking about how to address pain dismissal, we need to propose solutions that target each of these causes as well. And not just the causes, but the level of interaction those causes have, whether these individual one-off points of communication or on the structural level of what languages that we're using and what pain assessment tools are available to us. And I'll end it there. And again, this is the QR code for the GME credit if folks need it. Sorry, CME credit if folks need it. Thank you.
Thank you so much. The chat box is open for those interested in asking a question. Dr. Wiggleton-Little, I have got a bit of a historical take on this. I entered medical practice back in the mid 1980s. Yes, I am old. And during my academic sojourn, I had an appointment at the University of Michigan whereby this tempestuous physician by the name of Jack Kevorkian went ahead and did an assisted suicide on Janet Atkins, who was minimally symptomatic with Alzheimer's disease. That's not what I came to talk about. The next 3 patients with whom he used his suicide machine were all women. They were all experiencing, quote unquote, chronic pelvic pain, and they all wound up being non-terminal on autopsy. They just weren't being treated right. And so the long and the short of the Kevorkian assisted suicide and ultimately active euthanasia story ended with the state of Michigan instituting pain modules that must be taken by every single physician by the Michigan State Medical Society. But with that was one of the first locations where they had the emergence of a palliative care fellowship that we had to really take seriously, that people have pain, that we're not taking care of it, and that beyond the happy face to sad face scales, we need to be far more diligent in terms of caring for patients with pain. Part of the upshot of that, however, was how Big Pharma then said, this is great. Now we can go ahead and sell wholesale, like Costco, crates and crates, all the OxyContin for not just severe pain, but any pain. And then we wound up into the fentanyl crisis that we're currently experiencing. And so I remember when I first entered, I had patients who were using heroin way back when in the late 70s, early 80s. And now, back again, we've got people using heroin again. Did they do that because they had a pain syndrome? No, that it was a different issue. However, many of these did start on prescribed opiates. Then the opiates were then either non-obtainable or non-usable for them. They couldn't crush them and freebase them and that sort of thing. And then they turned to heroin, or nowadays they turn to fentanyl. So we now have a pain crisis in which if you have pain, there are legitimate ways of approaching it, but there's a part of physician brains that are going to say, yeah, but is this real? Or am I going to get in trouble with the DEA for setting up an agreement with the patient to start down the road of opiates? I'll let you respond.
Yes, excellent question. I think I have 2 thoughts that come to mind. One, bioethicist Travis Ryder in his book In Pain, he has this quote that I love where he talks about, and I completely agree with this, that we tend to conflate addressing and acknowledging a patient's pain with the opioid crisis, and that those two things can come apart, that we can show care and respect to patients in pain and simultaneously still address the opioid crisis. Because what I tend to argue is that taking my pain seriously, being able to believe and to elicit care and concern, doesn't have to automatically equate to a pharmaceutical prescription of any kind or to pharmaceutical treatments of any kind. So I think there's definitely ways in which, and then that's, and I'm appreciate the question, because I think in future works I can make this clear as another structural barrier I think that does exist. Is to your point that because we have these legal and moral pressures linked to addiction and managing the opioid crisis, that we sometimes fall back to doubting the patient. And I think those two things have to come apart. And so the structural piece is, how do we start to invest financially and with time of other ways in which we treat pain? And that's why I think palliative care has shined historically. And some palliative care centers that I've been able to shadow is that we acknowledge and recognize that pain is a whole body experience. It's not just something that can require some biological treatment, but it could be psychotherapy does work. We know that pain and anxiety are linked, that even those who struggle with opioid use disorder, if you actually manage the chronic pain, the anxieties or emotional components that link to the opioid use disorder start to have this kind of downgrade effect as well. So I think it's going to require therapy. It's going to require lifestyle changes. That it's going to require social determinant addressing. What are the stress that leads to the patient? Is multifaceted in a way that requires time. So what time do people have to even address the complexity of a patient in pain when an opioid prescription or any prescription is an easier fix time-wise, and one that our system seems to push forward?
In the chat, we have Trudy Singzon. I'm hoping that I'm pronouncing that right. This story is near and dear to my heart. I'm a palliative physician, and we are constantly having to remind the referring team to aggressively treat pain first. And then she has a part two. There is, of course, the concept of total pain, pain that is physical, emotional, social, spiritual. And we have to remind referring teams that they need to prioritize treating the physical pain and then reassess the other types of pain after physical pain is being better managed. Often the existential distress and even spiritual pain goes away once pain is well controlled. Then we also have another person, Faustino Gonzalez. I too trained in the 80s. I remember and regret the horrible way we treated pain, especially sickle cell patients. Now that I practice palliative care, the ghost of those interactions serves to remind me to believe first and then investigate. And then Dr. Wiggleton-Little, thank you. The information you shared, sadly, still needs to be spread far and wide. And the framework you provided for putting it all together is so helpful. Another structural barrier is access to many treatments such as PT, acupuncture, CBT, etc. And pain management is a team sport.
Mm-hmm.
Let's see. We have a question. Are you starting to see research with other marginalized groups? You mentioned other racial groups. Someone else mentioned the super crip stereotype for experiences of people with disabilities. Are we seeing any research on the experiences of members of the LGBTQ community or people of low SES, for example? And I can volunteer that in the Ehlers-Danlos syndrome community, of which I am part, this is a major area of influence that you see now in discussions on Facebook groups and things like that. But I welcome your comments.
Yes, absolutely. I've seen more research on low SES, and again, this idea that something about the exposure to poverty makes people resilient and strong and able to withstand pain. It's really fascinating when the different research that shows of who do we think is expected to be in pain or not. It's how attractive people find you, your age, your social class. Of course, we think we see a lot of impact that access to insurance can have on how willing we are to to provide certain courses of treatment, and then if it's feeling this pressure of not being willing to prescribe certain sources of treatment, how do we then unintentionally or intentionally undercut or dismiss the report itself? And then with regards to the LGBTQ community, I haven't looked at research specific to that community, other than the notion of weathering that's starting to come up and get some uptake. And as we see with the LGBTQ community and other marginalized communities, as we know, that this kind of reported exposure to microaggressions, to oppression, starts to wreak havoc on the body, and we see increased presence of chronic pain conditions in these populations. But as far as the unique ways in which LGBTQ community members are dismissed when it comes to pain reports, that is an area of my research I could definitely look into a lot more. I know for other forms of access to pain management, not pain management, of medical and healthcare, absolutely we see restrictions to access. But if there's specific stereotypes that's unique to pain itself, that's a good question I want to investigate.
So one thing that came through in that comment also is the cynical notion that adversity builds character.
Yeah.
No, adversity sucks. And what we as healers should do is do what we can do to ameliorate adversity and to heal the patient in the most efficacious manner as we are able to do. All right, I am going to thank our wonderful speaker for participating in this outstanding discussion, and I hope everyone has enjoyed this lecture. I do want to remind everyone that these are monthly during the spring and fall semesters. So our next Williams lecture is going to be on April 12th on moral distress. And that is going to be done by Professor Denise Dzinski, the past chair of the Department of Medical History and Ethics at the University of Washington. And I would like to personally thank Dr. Wiggleton-Little and all of the excellent questions that came in through our chat today. Thank you.
Mm-hmm.